Good afternoon. This is Barbara Brandt. I'm the director of the National Center for Interprofessional Practice and Education. And I'm pleased to present the webinar today, which is a part of our regular series from the Accelerating Initiative, the Accelerating Interprofessional Community-Based Education and Practice Initiative. Today we have Washburn University's Nexus team, and they will be speaking about improving health access for public housing residents. This is an accredited, jointly accredited opportunity. These are the professions that are accredited for those of you who are seeking continuing education credit. And the presenters have nothing to disclose and declare no vested interest or affiliation with any commercial interests. So today, Carla Dieter, as usual, and I are the facilitators for this Accelerating Initiative webinar, and we're pleased to do so. And here are your Washburn University presenters. Amanda Hartman, Mari Tucker, and Shirley Dingle. They will be presenting the Nexus program in Topeka, Kansas by Washburn University. So our objectives today are we're going to discuss how the Nexus IPE team was able to implement an academic practice partnership called the Nexus. They're going to describe how their team of students and health professionals actively learned and collaborated with community partners to improve health and well-being in the community, key lessons learned from their work with the National Center, and they will describe an application of at least one learning system tool supporting the success of their program. So we always start with the definition of interprofessional education. We proudly use the World Health Organization's 2010 definition that interprofessional education occurs when two or more professions learn with, about, and from each other to enable effective collaboration and improve health outcomes. And the National Center's call to action has always been, and no more than today, is that education and healthcare delivery must be simultaneously designed to be better integrated, more interprofessional, while demonstrating outcomes. And this is the concept that the National Center calls the Nexus. So Carla?
Hello, I'd like to just give a little bit of a summary of the Accelerating Interprofessional Community-Based Education and Practice Initiative. 4 private foundations came together: the John A. Hartford Foundation, Robert Wood Johnson Foundation, Josiah Macy Jr. Foundation, and the Gordon and Betty Moore Foundation. They came to the National Center for Interprofessional Practice and Education with a vision to advance the 2010 Future of Nursing Report, which outlined major recommendations for the role of nursing in the development and leadership of emerging collaborative care models. So the IOM follow-up report in 2015 and the progress from there, both those reports strongly highlighted the need for interprofessional education in settings other than acute care. So these partners supported the National Center to coordinate a one-time program, the Accelerating Initiative, and it was open to all schools with graduate health professionals, nursing, medicine, pharmacy, social work, and others, and other non-health related professional schools such as business, architecture, and law. And you'll be hearing about some of the more non-traditional partnerships that Washburn did today. And they came together. We had started off with 16 nursing schools. They had to be in a true community setting. It was a 2-year cohort. They were given $50,000 plus a significant amount of technical assistance from the National Center for 2 years. And then the sites needed to come up with a $50,000 match. So we interacted with them frequently. We also had an external evaluator, the Harder and Company, and I would invite everyone to look at nexusipe.org and look under the Advancing tab for the Accelerating Initiative for more information. I'd like to turn it over now to Shirley Dinkle, who is going to kick off the Washburn presentation.
Thank you, Carla. This slide really reflects the key points of our presentation and is self-explanatory, but I'd like to highlight three particular things. The first is the cornerstones. All foundational strategies that we used focused on people and communities first, and I think that's significant to the success of our particular project. Next would be unique partnerships. This clinic was developed from the community up. They led the initiative that they wanted, which improves our sustainability, and Mary and Amanda will talk more about that as we move along. The third key highlight is the Nexus IPE learning tool. It created a way for us to assess, plan, and make meaningful change. And quite frankly, we learned about this tool as we had moved into our project pretty far along. So it was nice for us to come back and reevaluate the work that we had done within a new lens. Now, before we move forward, I'd like to say one more thing, in that we are all doing healthcare and education in this time of COVID, and our processes will be reflected throughout. First, COVID is tragic and life-changing, as we know. However, we in this particular project are uniquely prepared to transition, as we have learned so much about resilience from our patients and our community members. So our IPE team is more resilient as a result. So next, Mary will take it forward and speak about our community. Next slide, please.
Good afternoon. So our partnerships were a little bit unique for this project. The School of Nursing and the Office of Sponsored Projects had a very strong relationship prior to the Classroom to Community project. We worked on a lot of different grant projects. And so I was the director of the Office of Sponsored Projects at the time that we had this opportunity. And Dr. Dinkle had a unique idea of expanding the traditional IPE concept to include disciplines outside the School of Nursing. And so we included the School of Business, the Department of Communication Studies, and the Department of Social Work, and selected students within each of those programs to work with us in this project, and faculty from those programs were also integrally involved. We had a strong relationship also, the Washburn School of Nursing did, with the Topeka Housing Authority as part of a prior project that established a wellness clinic in a public housing authority community. And so this project allowed us to expand on that to include a local advisory firm, Advisors XL. They are an investment firm. They do a lot of charitable work within the Topeka community, contribute to a lot of very worthy causes. And then, as Shirley mentioned, the THA residents were really integral partners from the very beginning. They helped us determine what they needed. We focused on what they needed and what their wishes were for healthcare, instead of trying to determine that and establish something that we thought would work for them. We really included their input and requested their feedback on that. So next slide, we'll look at, so the community in general. The Topeka Housing Authority manages 744 public housing rentals in Topeka, and they assist over 4,000 people every day with housing. There are a significant number of those individuals under the 18 years of age, and also over the age of 55, so young individuals and the over 55 population have a significant number of them have disabilities and pretty complex health situations. The authority pays over $6 million a year to Section 8 landlords, so they manage not only public housing but also Section 8. And THA Inc. is the nonprofit agency within the Housing Authority that does a lot of the community work. So we look at the next slide, will give you some details on the Pine Ridge neighborhood in particular, and that's the neighborhood where the primary care clinic is located. So there are 463 residents there. 243 of them are under the age of 18 and 42 over the age of 55. You can see the demographics of that population. And again, the Pine Ridge neighborhood is the Housing Authority's oldest and largest public housing neighborhood. And Amanda then will visit or describe our cornerstones of the project.
Thank you, Mary. As far as our cornerstones identified for this project, Shirley touched on that briefly. Our clinic was developed from the community up. First, I'll discuss the community-based participatory research aspect. This is a design approach that builds and maintains community trust and true collaboration through equitable involvement of all partners in the research process. This was a really integral part of our research and development prior to building the clinic. We held two informal discussions and then developed a comprehensive community needs assessment that was delivered to the Pine Ridge community. Resident knowledge and mentorship influenced the design and implementation of this locally relevant community health needs assessment for the Pine Ridge Manor. Our overall goal was to discover what matters to the Pine Ridge Manor community instead of what is the matter with the Pine Ridge Manor community. This leads us to our next cornerstone, which is the social determinants of health. These are socioeconomic and psychosocial characteristics that can impact personal and community health. Pine Ridge Manor was identified in the Center for Disease Control's 500 Cities project as an area with significant behavioral risk factors which influence health status and health outcomes. Pine Ridge Manor is home to approximately 500 people, half of whom are 17 years old or younger, with 90% of the residents living at or below 100% of the federal poverty level. To fully understand our future patients' complexity, we needed to assess the non-clinical factors that influence their health, utilization of services, the amount of services needed, as well as any additional assistance that a traditional clinic might not provide. These are things that often aren't accurately reflected or captured in traditional demographic and clinical information. Thirdly, culturally relevant healthcare. We really focus on the idea of working with, not for, the Pine Ridge Manor residents. The three primary lessons learned from the C2C place-based initiative is first, building trust with the residents of Pine Ridge Manor was a major consideration in the development and planning of all the proposed activities relating to this project. Being acutely aware and sensitive to relevant social justice concepts, such as the white savior complex, has helped guide us through this project's introduction and integration into the Pine Ridge community. Striving to work from a perspective that is free from elements of saviorism and taking time to explore our own personality has been helpful in this exercise and in expanding our foundation of trust. Secondly, cultural and linguistic competency was evident in the development of the community assessment survey, which included resident participation and feedback. Careful attention was paid to reading level, a balanced view of community assets and concerns, We paid really particular attention to the survey length and made sure that we were phrasing in a non-invasive tone. The survey was offered within a community setting, and this really helped enrich the budding relationship between the residents and the collaborators, and this really resulted in a multi-directional mentoring opportunity. Third, the cultural congruency aspect is vital when working with a diverse team and communities. One fundamental concept in cultural congruence is recognizing one's own bias. The C2C team has come to understand that the preconceived perceptions of the Pine Ridge community were not accurate, and interactions have exposed more commonalities with the residents than expected. Residents hold a deeply rooted sense of community and a strong desire among community members to work together to improve the quality of life at Pine Ridge Manor. The opportunity for personal and group self-reflection and discussion of changed perceptions have and continue to be profound and transformative. And lastly, the last cornerstone is the Kennedy model of sustainability. Next slide, please. At this point in the presentation, I will just briefly review the Kennedy model of sustainability, and then later in the presentation, we'll do an in-depth approach to the application of the Kennedy model of sustainability. So this was our tool of choice, our selected Nexus IPE learning system tool. And this was integral in, and continues to be integral as we move forward with our clinic. The first aspect of maintenance of mission and activities, the institutionalization of organizational infrastructure, the community visibility, and the strategic response to change will all be reviewed in depth later in this presentation. Next slide.
All right, this is Shirley again, and we would like to start the conversation with what we call the simultaneous emergence, because our particular project initially focused on curriculum development because Washburn is not affiliated with a major healthcare agency. And we can't talk about the clinic without talking about the curriculum, and we can't talk about the curriculum without talking about the clinic. So Mary frequently states that Topeka Housing Authority is successful because of the focus on community conversations, and our Nexus initiative is really no exception. Now, most of you have heard the story of how the project started, so I'll give it to you in a nutshell. To me, it's an amazing story. And first of all, I want to start by saying that Pine Ridge Family Health Center is the only known primary care clinic in the nation that is owned and operated by a housing authority. And I think this is one of the things that makes us incredibly unique. So Washburn BSN faculty talked with residents about wellness, and Mary talked about that just a moment ago. And then DNP faculty were invited into the conversation. And this is a piece of those community conversations that continually happen at THA. And then at the same time, an email appeared from Nexus, ta-da! And the C2C project was born. So it started with curriculum with unique partners, including the School of Nursing, the School of Business, Social Work, and the Department of Communication Studies, as well as the Office of Sponsored Projects. There we discussed how we might operationalize a new IPE learning experience. At the same time, conversations began to happen with community leaders, faculty, and students, and THA leadership. And together, these curricular conversations and these community conversations began to include residents and what do residents want as part of their community. And they identified their healthcare needs, their potential solutions, and Pine Ridge Family Health Center was born. And today we are year 2 within our practice, and we'll talk more about some of those particular outcomes related to the clinic itself. But I'd like us to start first by our compelling vision of our project, because again, I want to reiterate that without the curriculum, we don't have a clinic, and without the clinic, we don't expand on our curriculum. And so I'll turn it back over to Amanda. Next slide, please. Oh, that's too far.
I think you missed one slide, Shirley, number 16.
I sure did, didn't I? Oh, okay. I lost it. Yes, thank you very much. I'm not going to turn it over to Amanda. I'm going to turn it back over to myself.
Very good.
One of the things that has really been interesting is that we've just created this opportunity for mutual understanding. And I think it is so reflective of what the process has been for the C2C project. So curriculum and practice come together and are really reflective in what I know as the Fibonacci spiral. And the Fibonacci spiral is a geometric pattern where a circular arc connects opposite corners of squares, or is also called the golden ratio. Now, I am no mathematician, but this mathematical equation is reflected in the natural world and in art and in other kinds of processes. And I think our experience at Pine Ridge Family Health and with Washburn University is reflected in this dynamic process where creating a clinic was a manifestation of curriculum goals. We honor this process as we move in and start in an unknown direction, and we move further into an unknown direction as the pandemic has shifted our thinking about care delivery and student learning. We embrace change as part of each person's leadership development and mutual mentoring. Patients, providers, students, faculty all take turns in mentoring, and it's often an unplanned process and develops naturally on its own. So this, I think, really depicts what our process has been, an ever-evolving process, reflective in art and in nature. So thank you. And Amanda, I'll turn it over to you.
Thank you, Shirley. Our compelling vision statement. This project supports a university and community collaboration to address the health needs of our city and our county. In the IPE curriculum, the combination of health and non-health disciplines will transform IPE education and engage community partners to form the basis for sustainable, improved primary health services for the underserved members of our community. Again, it's important to reiterate that we're working with, not for, our Pine Ridge Manor residents. Next slide, please. Our compelling vision in action. Using the concepts of mentoring, community-based participatory research, and interprofessional education, the C2C project created a cutting-edge, nurse practitioner-driven primary care clinic embedded in a medically vulnerable community. This innovative delivery system will bring team members and Pine Ridge Manor residents together to improve residents' health indicators and remove barriers to achieving holistic health. While the full impact of this project has yet to be discovered, it has the potential to shift the traditional healthcare delivery emphasis of taking care of patients to one of co-creation of a new healthcare model where patients are fully engaged in their own healthcare delivery. It is our hope that the C2C model can be replicated within academic practice partnerships of public housing authorities across the nation. Next slide, please. As far as our progress and client outcomes, we have really taken off over the past 12 months. As you see on the slide, we've had over 2,500 total encounters at this point. 863 of those have been new patients. We have tripled our encounters since our opening in 2017. As far as the impact of the COVID-19, honestly, the only difference is we're delivering our health services remotely using telehealth. we're still seeing and taking care of our community as we normally would. So honestly, because we had just a unique model to begin with, the COVID hasn't greatly impacted the way that we're delivering care or the number of clients that we're seeing. It's really just we're separated. We're not face to face. As far as our patient satisfaction, we have a really high satisfaction rate at this point. And again, I attribute that to our non-traditional model as far as really integrating the residents within their own care delivery. And so far it's working. So now I will turn it over to Shirley. Or Mary, excuse me.
So in addition to clinic outcomes, we've also had some really significant academic practice partnership outcomes. We have had Washburn students from a wide variety of disciplines, including business, social work, communications, law, complete clinical hours and student projects with the Housing Authority and at the clinic. The clinic is a partner with us on 2 different HRSA federally funded grant projects. The Renew project is focused on BSN education and training nursing students to work at what we are calling the full scope of their licensure. So moving them from acute settings more into primary care, ambulatory care. And the Be Well project is focused on DMP education and the integration of behavioral health into primary care. Students in both projects complete traineeships and clinical rotations through the clinic, and Dr. Dinkle is providing preceptor services for both projects. As a result of that, one of the BSN participants will become the RN nurse navigator at the clinic as soon as she graduates from Washburn in the spring and passes the NCLEX certification. COVID-19 has changed the face of student clinical experiences. We have been forced to resort to more simulation as our partners are restricting clinical visits. But that has gone very well, and we still do have a few students out with our partners doing clinical experiences. And it's been a real bonus in that we have been able to fully integrate telehealth into clinical experiences, which prior we had not focused that much on telehealth, but it's given us an opportunity to really expand in that regard. We continue to move forward as a team in a revised format and different partners as some of the partners have transitioned out and new partners have transitioned in. A key deliverable for our team was a poverty simulation event, which we held last April. That activity took place at one of the Housing Authority's community centers and brought together students, faculty, and public housing residents for an insightful, thought-provoking simulation of living in poverty. The students experienced the challenges of navigating social support services, transportation, childcare issues, and not enough money for the monthly necessities. All of the students and faculty who participated in the project in general, the Classroom to Community project, have completed evaluations which assess the appropriateness of training and the overall clinical experience. And by and large, it has just been a very, very positive experience for everyone. And Shirley can expand further on the community partnership outcomes.
Thank you, Mary. I think this has been one of our biggest successes is in how the clinic has reached out and joined hands with our community partners. As Mary said earlier, we have had a 20% reduction in emergency room visits, and I think that speaks for itself. As far as Topeka Housing Authority and THA Inc. are involved, They are our new partners in the Nexus, in that staff from the clinic go to monthly staff meetings where we will work with maintenance folks and supervisors and intake people and pest control, and we all talk about how each of us influence the healthcare of our community. An example is that we had a patient who was pretty distraught that her bush in her front yard was dying because of bagworms, and we were able to talk with maintenance, who went over and took care of that particular bush in this woman's yard, and her social environment and her physical environment became more appealing, and she talked about that when she came to the clinic. So those simple things really make an impact on our residents. The Pine Ridge Partnership is, Mary mentioned it earlier, in that the clinic serves as the school nurse for the preschool and communicates regularly with USD 501 to provide sports physicals for middle school and high school students each year for free. Staff also help identify and refer students in need of additional services. We've also increased the number of our partners. Positive Connections is an HIV, STI, and hepatitis screening and support agency in our community. We work with them regularly to provide follow-up care for those who have been tested positive. Mirror is a halfway house who we have recently partnered with, people who are released from prison and are living in the halfway house. We are now serving as their primary care provider. And then Health Access is a very unique partner that we have in Shawnee County. It is not health insurance, but it is donated services by specialists, physician specialists, and hospitals in our community who provide free care based on a referral from our clinic. We are currently working with Health Access right now, where we have a grant to house an in-house community navigator to serve our clients. Also, I now serve on the board of Health Access, which increases communication and opportunities between the programs. Hospital partners, we are now receiving voucher money from one of our local hospitals, in that patients who don't have a primary care provider, they're referred to us, and then the hospital donates $50 to the cost of that first visit for patients. We also get financial support from both hospital foundations. And then we also are working with El Centro, which is a community organization that serves the Spanish-speaking members and residents of Topeka. And so we are beginning to see an increase in the number of patients who are Spanish-speaking, and most of which who are without papers. Now, as far as how this is pivoting related to COVID, is that we are really expanding services to reach out to other organizations that are serving our population. So first of all, I want to say one of the reasons why we are successful at Pine Ridge Family Health is because of our CEO of Topeka Housing Authority. He is a very responsive leader. And when COVID was first being recognized as the pandemic that it is today, Mr. George was very eager to be proactive instead of reactive related to what we would be doing at Pine Ridge Family Health Center. The other thing is that he quickly adopted telehealth, and the staff did as well. So that is a community partnership that we're reaching, in that we will have translators, some of which are from El Centro, who will meet with us during a telehealth visit to help with some of those communication issues. We've also been able to meet with some of our health access partners via telehealth to expand services to our patients. The other fun thing that we're starting to do with telehealth, while it has reduced our overall student experience at the clinic, we are now beginning to introduce students back into that telehealth experience. Well, they'll see patients as well as I will. We have 2 students who are working to complete their projects via telehealth now at the Pine Ridge Family Health Center. The other thing that I think that we've been successful, reason we've been successful, is because we've really kind of focused on the quadruple aim. We are a very nimble agency, and we are accessible. We have visionary leaders such as Trey George, who I mentioned a moment ago, and Mary Tucker, who is on this presentation, as she serves as the chair of the advisory council. We are also quite comfortable with chaos and change, and we've talked about that a lot. And then lastly, we have satisfied patients and providers. So meeting of the needs of these vulnerable patient populations has really increased because of that vision and that nimbleness that we have. Lastly, I'd like to speak to the resilience of our patients and residents and why we are so successful at Pine Ridge Family Health. It's because they are eager to embrace new ways of communicating. They have adopted email and text and phone calls and home deliveries and curbside care, and they are very happy to help all of us transition into this process together. And I think that is such a remarkable thing. We have learned so much about resilience from our patients themselves. Okay, Amanda.
So what are the key lessons that Washburn teaches us? Well, speaking for myself, flexibility is key and being agile is essential. Letting go of what we predicted the plan to be and embracing our relationships as they are currently and as they evolve. We're working through some new leadership positions. We have new working dynamics and dealing with our own personal expectations while keeping the patient experience central in our minds. There have been a lot of changes on the academic partner side. As far as Washburn University, the School of Nursing has a new dean as well as a new associate dean. Our School of Business partner, our chair member of the C2C team has stepped back from participation currently. There's a new director of the MBA program at the university. And one new approach that we're trying to embrace the School of Business is rather than asking them to come to us, we are coming to them. I am now embedded as a School of Nurse faculty member, co-teaching with a School of Business faculty member within an entrepreneurship course that all graduate nursing students need to take. So this is the first semester we've piloted that approach. And so far it's positive. So my hope is that, while we're giving the nursing students a more positive experience with business in general, is that we can then redevelop a strong relationship with the School of Business and hope that they can come back to the table as part of an academic partner. As far as the Department of Communications, they continue to be an active member of the C2C curriculum team, and they implement our curricular modules within their courses. We have added 2 new faculty members from the School of Social Work, and they're very active in the meetings of the C2C team. Struggles that we're seeing, we're still disconnected between our graduate students and our undergraduate students across all areas, not exclusive to the School of Nursing, but within the School of Business, Communications, and Social Work. We need to work on establishing a more solid relationship with our School of Law, and we need to work on establishing a more solid relationship with our allied health programs. Essentially, as far as our academic partner, Washburn, is concerned, this is a rebuilding year. There's just been major changes, and it isn't that they aren't interested in being dedicated to the C2C project. It just isn't the priority this year. But I foresee that changing over the next year as I'm still working very diligently to keep C2C in the forefront, at least in the School of Nursing. As Mary is working outside of the School of Nursing, she organizes all of our C2C meetings and is really working hard to engage other partners within Washburn. As far as the clinic and the Pine Ridge Manor changes, most successfully is our community input. We have a lot of active community members in decision-making and within the oversight process. As far as changes that are occurring related to sustainability, we wrap back to our initial health needs assessment, in which people stated they did not expect free care. We've been consulting with our resident members and the advisory council, which is reconfirming that, as we in the clinic are working on adjusting our financial policy and billing practices to balance our clinic financial needs while being mindful of not inflicting undue fiscal stress on our community members. We're continuing to work on our sustainability related to the aspects of the Kennedy model. Next slide, please. And this brings us back to the Kennedy model of sustainability. And it's my understanding that Terry Kennedy is here with us today, and she will be able to help field questions specific to her model. So I am very grateful for that. But as we look at the Kennedy model of sustainability and how it applies to the C2C project, as far as the maintenance of mission and activities, the institutional infusion efforts were completed by weaving our IPE content and concepts into curricular activities. Our beginning curriculum was founded on the principles of IPE, the community-based participatory research, culturally relevant learning experiences, mentorship, and from those items, we created 10 curricular threads. Those include team steps, the quadruple aim, quality improvement, leadership of self, social justice, sustainability, motivational interviewing, crisis communication, business ethics, and trauma-informed care. The application of these threads results in a cutting-edge primary care clinic, which is the Pine Ridge Family Health Center, that's embedded within a public housing community. It's the only such in the nation. All of our partners, residents, students, faculty, and community leaders contribute expertise and shared decision-making and ownership by working side by side to co-create a culture of health. Okay, I was just reading the chat there. Okay, and it looks like we're moving on to the next slide. So give me 1 second here. The classroom to community model. Really, the key to this is mentorship. A quote that comes to mind from John Crosby is, "Mentoring is a brain to pick, an ear to listen, and a push in the right direction." Lifelong learning is the key to success, and there is knowledge and experience to share with others who hope to tread the path already traveled. Our project utilizes bidirectional self-selected mentoring among the C2C members, Pine Ridge Family Health Center staff, and THA Inc., and Pine Ridge Manor residents, where each person serves as a mentor. As far as adopting the Kennedy model, that again has been really essential to developing our sustainability plan. As Shirley discussed briefly, our new relationships within the community with Positive Connections, Mirror Health Access, our new hospital ER referral program, donations from hospital foundations, and our new relationship with El Centro within the community. Additionally, we've changed the way that the clinic is operating staff-wise. At time, we are operating with one full-time nurse practitioner. We have a part-time nurse practitioner. Hold on, I'm looking at the chat here. This is a little your curriculum. Okay, so I guess we will just answer questions at the end. It's hard when things come over in the chat and not the Q&A, because I'm not sure if that's a message to me, so I apologize for stopping. Currently, we're staffed with one full-time nurse practitioner, a part-time nurse practitioner. We have a full-time administrative staff, and we've recently implemented a transportation specialist. And then we have our nursing student that will soon be our full-time registered nurse as soon as she has completed her training and passes her NCLEX. This is an example of how we've adapted to the change in demand and the needs of our community so that we can meet their needs and remain sustainable. Okay, and next slide.
I get that. So what we have done, what the National Center has been able to do throughout this whole experience with the Accelerating Initiative programs has to help scaffold for them. So we have identified where people get stuck, and we call them pain points. And we do have a Nexus learning system and with various tools to help teams through their different situations. And so that's why one of the things that we've been doing with each of these accelerating webinars is to highlight some of these tools. And one of them was the Kennedy sustainability model. One of the things that even highlights that, just to really highlight the fact that this program started off with $50,000, and then $50,000 match, which is not much. And you have heard Washburn talk about really how they have expanded their reach and have increased their sustainability, and they've been able to change and be nimble and let go of their initial plan and really fit into not only the situation, but fit into other strategic plans and make sure that they're meeting the needs of their residents. Next slide. This just shows the website, and then the next slide I think is upcoming webinars in this same series. And I'm going to, we've got about 15 minutes left, and I'd sure like to be able to turn this over to Barbara. Was going to manage the questions, and I'll let Barbara start off with the questions, and I will. And then Shirley and Mary and Amanda can help answer.
So thank you, team, for the work you've done. Is very inspiring. I just want to underscore, when did this clinic open? What was the date?
It was open in 2017.
Okay, so what I want everybody to appreciate is there was no clinic here. They spent the first year really engaging the community to plan a community responsive clinic. They had to learn how to do third-party billing. They had everything that they've talked about today was the ground up and started. I mean, they have their own business now. So, and then, yes, they had very non-traditional partners to do this. Which was actually ended up being just really contributing to the outcomes. The other observation that I want to point out is all of these, I would call them, you look at them as challenges and where you are in your history, we would just call that critical events of IPE. These are normal occurrences that you're navigating through, but you have a very, very strong program. And the other thing I want to underscore that you talked about with your response to COVID. So we've been doing individual follow-up with these sites, and a theme that's coming out is that these sites have been built in the community. They're very community engaged, and for the most part, they've got out in front of it pretty quickly, and the results that they're demonstrating today are pretty impressive. So this is another story that we're hearing in the other sites also. So I'm going to ask people who do have questions, and I am going to ask, we're going to answer a couple questions, and then I do want Terry to reflect on, so Terry Kennedy is on some of her thoughts about the sustainability model, because I know that she was a coach to this also. So one of the questions we have is, what allied health programs do you have at Washburn, and how would you see their roles in the clinic?
We have several allied health programs, physical therapy, occupational therapy, and exercise science. So as far as their involvement, I think it would be more of a hands-on physical involvement, but that isn't something we've been able to achieve just yet, but we're working on that.
Okay.
And this is Mary. I might just add the allied health programs are within our School of Applied Studies. So within that school, there's also criminal justice, legal studies, trauma and recovery services. So there are a lot of opportunities within the School of Applied Studies to also bring them into our C2C team. So they're, aside from the actual physical work and direct healthcare, there's also some possibilities for that.
Okay. We have another question that help me to understand your curriculum. Is it a separate IPE curriculum, a curriculum that partners with undergraduates, graduate nursing, and the other colleges?
So our curriculum is dynamic in that it can be applied in multiple areas and is at the discretion of the individual school and coordinator of their own course, or each professor. As far as the School of Nursing, in regard to the graduate program, all of the curricular threads are a requirement and are applied either directly through their didactic assignments or through clinical experience opportunities throughout their program. We, in the School of Nursing, didn't feel that it was appropriate to try to demand that any other school use our developed modules in any particular way, but we have invited them and made them readily available for use at their own discretion.
This is Shirley, and if you don't mind, I'd like to add that the poverty simulation was the way to bring all of the schools together in one unique activity so that they could share their professional lenses as part of the discussion. That poverty simulation also included residents from the community. And what we found is that we, as a team, all of us in the room, had more in common than we did separate. So I know that the campus C2C team is working on how to create those learning opportunities where all schools are involved together.
So this is Barb, this was the most unique implementation of the poverty simulation that we've seen, and we've seen many, in that the residents were very involved in that simulation, which made it a 500 times more richer and place-based. It was just phenomenal. We have two questions, and I'm looking at the time. We have about 7 minutes. And the questions actually are very much about the findings across all of our sites, but they're directed specifically to Washburn. So one of them is, did you have existing smaller activities ongoing with a community partner, or was this a new collaboration? And one of the strongest findings of the external evaluation is these sites tended to build upon existing foundations. So I'll be interested in hearing Washburn. And then related is, how did you go about identifying partners with your schools and community partners? Did you have champions in schools that self-identified, or did you seek them out? So that's kind of a constellation of questions about partnerships inside and outside the university.
I'd like to start, this is Shirley, and I'd like to start that conversation. And I know Amanda and Mary will have much to offer in that it's challenging to put into words how it happened. And I know I've expressed this many times to both Barbara and Carla. So as far as the community partners were concerned, we had a relationship with Pine Ridge Manor. our BSN faculty had started a wellness clinic, and we were invited, the nurse practitioner faculty were invited to come over and help the Pine Ridge Prep, the preschool there, do Can Be Healthy physicals. And so that was that beginning community conversation. So BSN faculty and BSN students had been there. DNP faculty were invited in, and we thought, gosh, this is awesome. How come we don't have DNP students in here? And then all of a sudden we had that change, that shift in thinking about possibilities at Pine Ridge Manor and the development of the clinic. At the same time, partners in the School of Nursing and at Washburn University were really partners that were already established. Our curriculum for the DNP program required that students take 12 hours within the School of Business because we believed that business is one of the partners with healthcare. And so we had that relationship already with the School of Business. We also had worked very closely with the director of Office of Sponsored Projects, and that is Mary Tucker. And she had helped write many grants for the School of Nursing. And we thought, well, why wouldn't she be involved in that conversation? Because she's been instrumental all along. So really, we had connections. We just had the opportunity to look at connection through a different lens. Did that answer the question, Barbara?
Yes, what I also, and I want to get the last question is about sustainability. And I do want, if Terry has anything she wants to add, what I actually want to also underscore to this team and to everyone on this call is that this team has a sixth sense about partnerships and sustainability. We did coaching, yada, yada. And however, that is a key to the success. And all of our sites, almost all of them are sustainable. The money that you received was not a lot. We did a lot of coaching, but it was so it's not about money. It's about something else. So I want to open it up and just talk a little bit about sustainability. And Terry, if you have anything else you wanted to add, we'll open it up so you can also share.
Okay, thank you so much. Can you hear me all right?
Totally, you didn't know this was happening. So.
I had no idea. So it's great to talk to everybody. Shirley, Mary, and Amanda, it's nice to reconnect with you and my fellow Kansan Missourians here. So Shirley, you did a beautiful job talking about the maintenance of mission and activities. And so I'll leave that one and I'll just give, what was just discussed in terms of who was at the table, who was part of this process, was a really important demonstration of institutionalization of organizational infrastructure, where you're really identifying who are the stakeholders and invited, interested, and collateral parties. So that's just sort of a brief example, but I think it reminds us about how important it is to think about not just the usual suspects, but who else is interested and has contributions that can really benefit. So bringing in business and bringing in sponsored projects was really important in this project, and having that real solid relationship with the housing authority and the community. In terms of community visibility, not only did Washburn become integral to have a project that was, kind of reaching out from the university, but they really did become integral to the culture of both the community and the university through this project. So that community visibility was really present within the community, the broader community, and within the university. And then finally, you heard the conversations about the critical events of IPE. I think, again, what was remarkable and successful for this team was their ability to pivot when there were these issues. So rather than having things stop them in their tracks, they were able to make necessary changes. So they had the real success of the strategic response to change.
I would say the other thing, and so we talk about our teams and what we're seeing. And so for the Washburn team, and you have a whole slide on it, is taking the time for mutual understanding. And so you've built the trust and all the things in teamwork along academic community partnerships. And so that, it's been remarkable. And then you had a business school involved. So how's that?
Yeah, I think that's it in a nutshell. And Terry, I really appreciate, and Barbara, both of you, your comments about having a sixth sense about partners. And much of what we did was not intentional. It was just willingness to ask, are you interested in participating? And if not, then we would just move on to the next person. And those who want to participate will participate. And I think that has been really key to us being able to move forward.
So I'm looking at the time. It is 4:00 on the dot. And I want to thank the Washburn team. Terry, I want to thank you too for impromptu advice, for participating and to giving a terrific webinar. It'll be archived. Those on the site can get access to it and broadly share. And we need to let this team go because they have to leave for a doctoral dissertation defense. So again, thank you very much. You're all very inspiring, and thanks to those who have joined us today. Good afternoon.
Thank you.
Thank
you.
Carla. Bye-bye.
Bye.
Bye-bye.